All right, we're live, and I'm gonna set up. I got like 30 minutes. I'm gonna do 30 minutes. Coffee time. So I have a test on Wednesday, and I'm just gonna do a live. I'm gonna just go live and try and get it on. Like the internet's really slow. I'm gonna go live, and I'm just gonna like kind of out loud go over um, my paperwork, what I'm studying. So I think it's renal, and I think I think my last test was endocrine neuro. I think the last test I had, test 3, was endocrine neuro. I think, and I think we did okay. I got a 90% or something. So I think my total grade is a 95 in the class. So, okay, what is this again? Okay, lecture, clinical material. No, lecture material. Okay, here we go. Sometimes, I just have trouble navigating all of this stuff. Neurological dysfunction, end of life, acute kidney injury, GI dysfunction, case study, neurological dysfunction. Okay, oh no, I honestly don't even know what this test is on. Okay, we're gonna find it. We're gonna find out. Here we go. Downloading the schedule. So I just did 2 shifts. I just did Friday I did 11A to 11P in the ER as a nursing extern. So I got to try my best to be the nurse, unlicensed, but under my nurse. And then Saturday I worked 7 to 7. So I got off at 11:30, came home, and then had to be back at the same freaking hospital. At least I work at the same hospital. It could always be worse. But I had to be back at the same hospital at 7 in the morning. So I'm still recovering from that. Okay, here we go. So exam. Okay, so I did the endocrine neuro. Now we're doing acute kidney injury and GI and professional development. Oh no. 10:24. Oh, thank God. Oh, I thought we had a test next week. We don't have a test next week. Oh wait, we have a test next week, not this week. Wait. Yep. I don't know. I don't know. I don't know what's going on with my life. This is home stretch. I'm checked out at this point. Pretty checked out, I think. I feel like I'm to the point where it's like I know what I know. Know what I know. And if I don't know it, I freaking should have been studying, I guess. I don't know. What I'm talking about a lot. Okay, here we go. You can close it if I'm too loud. GI lectures, acute liver failure. Okay, let's do this GI case study. GI bleeding case study. Okay. Biliary tract, pancreas problems. Liver, biliary tract, and pancreas problems. Mr. Blank is 55, Native American man. Okay. Admitted with diagnosis of cirrhosis. Okay, so I know cirrhosis pretty well. I mean, yeah, okay. I know the basics of cirrhosis. Subjective data. He's had cirrhosis for 12 years. And this is just a case. This isn't real, so we're not actually talking about anybody. Acknowledges that he has been drinking heavily for 20 years, but he has been sober for the last 2 years. Okay. Complains of anorexia, nausea, and abdominal discomfort. Okay. So the objective data physical exam. He's thin and malnourished, so cachectic. He has moderate ascites. Okay, well, so minimal, moderate, severe. So maybe it's not hindering his venous blood returns, not hindering his volumes, tidal volumes. Moderate sized jaundice of sclera and skin. Okay, so he's ecteric. So we know his belly's good. I got lost there. So he's got moderate ascites, edema, lower extremities. Liver and spleen are palpable. So if you can palpate the liver and spleen past the ascites, then yeah, it must not be that bad. Okay, labs. They give me a few labs. So my total billy, my T-billy is 15. My serum ammonia is 220. So serum ammonia 220. There you go. That's big. That's a good one. AST's 190. ALT's 210. Okay, so they're elevated, but they're not like markedly elevated. The serum ammonia is way high. He's going to have encephalopathic symptoms. How you think he'd be encephalopathic at this point at 220? What are the possible causes of cirrhosis? Well, what are the possible causes? Well, I think hepatitis can give you cirrhosis. Alcohol, fatty liver, maybe. I think there's like congenital things that can cause liver failure. Shock. I don't know if shock liver can cause cirrhosis. It can cause necrotic liver. Okay, like ischemia, but no, cirrhosis is more scarring. What types of cirrhosis does Mr. Big A probably have? I'm gonna say probably alcoholic cirrhosis. All right, so before I continue, here's my critical thinking questions. I'm gonna pull up. They have the answers for me, so that I can see how I stack up to what they want me to know versus case study answers. Oh, they didn't even have them out yet. Oh, that's annoying. So I can't even really study. This is great. All right, so I'll just keep going. Describe. Okay, well, let's just Google it then. So, we'll type causes of cirrhosis. Cirrhosis is spelled weird. Yep, hepatitis. Okay, so cirrhosis is complication. This is from medicinenet.com. I don't know how valuable. I mean, it's probably okay. Mayo Clinic, we can check the Mayo Clinic. So, cirrhosis is a compelling complication of liver disease. It involves loss of liver cells. Okay, I knew that. And irreversible scarring. I knew that. Of the liver. Okay. Alcohol, viral hepatitis. There you go. Hepatitis. There you go. Hepatitis B and C. Common causes. So, although there are many other causes. Okay, well, what are the other causes? Oh, okay. See, this is where I could open my book, but honestly, the book is this big. Look at this. This book. Look at this thing. I have the book here. It's so big, and I don't open it, and I don't look at it. This is my nursing book. And it's not even up to date. This is the old version of the nursing book. I'm not going through. Oh, and then there's another one. Hold on. There's another book. There's another one. Look at these. Look at these things. I'm not going through this. I have the internet. Toxic metals such as iron, copper that accumulate in the liver as a result of genetic disease. Okay, autoimmune liver disease in the body is immune. Okay, so so autoimmune viruses, toxins like heavy metals, alcohol is most common. I don't know if fatty liver disease causes cirrhosis. Maybe it does. All right, that's enough. I don't need to go so in depth. It really doesn't matter. Describe the pathophysiologic changes that occur in the liver as cirrhosis develops. Okay, so let's see what I got off the top of my head. So liver, what's a big thing? Liver produces albumin, right? So albumin, you're going to not have a good intravascular pressure. You're going to have third spacing, right? They produce cofactors for platelets, so their PTINR may be prolonged. PTC might be prolonged. They might be at risk for bleeding. Liver. What else does liver do? Liver, clears out toxins. So you might have medications build up. They might be able to tolerate have normal doses. You might have liver, like hepatic care doses for medications if they're processed by liver, like Tylenol is processed by liver, so that can be an issue. Ammonia is not able to be converted into like urea, something like that. I just know ammonia breakdown of proteins not able to be converted. It can cause encephalopathy. So what else does it do? Also, okay, so that's like what the liver does, I guess. It also does a lot of stuff. Makes lots of proteins. It's a portal, right? So it's a portal for the GI blood tract. So if it's cirrhotic and scarred, it's not going to have vasculature available. Also produce ability to say so. Yeah, of course, follow the tree. So you produce bile for a breakdown of fat to be sent to the gallbladder and in the stomach to be released. So that gets all clogged up. They're not able to metabolize fat. So you'll end up having steatosis. That was called statorrhea. It's called statorrhea. So it's like statorrhea, something like that. Poop. You get fat in your poop. Okay, so describe the pathophysiologic changes that occur in the liver as pathophysiologic changes that occur in the liver as cirrhosis develops. So you have the little hexagonal or little clusters. What are they called? So yeah, I mean I know basics, but I mean if I start talking about details, I'm like, let's go liver histology. Just look at the liver histology label. Here we go. So yeah, okay, central vein, yeah, okay. Intralobular septum, don't need to worry about that. Intralobular branch of the portal vein. Okay, bile duct, yeah, hepatic artery, okay, portal triad, hepatic cords, and the sinusoids. Okay, so these, let's look at another one real quick. Okay, so distal convoluted tubule, no, that's not it. Okay, sinusoids, so that's what they are, sinusoids. Central veins get clogged up, bile ducts get clogged up, so everything starts to back up into the portal vein. Pathophysiologically, the scarring is produced. These are less vascular. It's just much collagen, so that causes blood to back up and doesn't allow it to be filtered through the sinusoids. Is that what it is? Sinusoids. Okay. Sinusoids of the liver. Signs of low pressure vascular channels. They receive blood from terminal branches of the hepatic artery and portal vein of the peripheral walls and deliver central vein. Sinusoids are lined with endothelial cells and flanked by platelets, the plates of hepatocytes. Yeah, so that's kind of where the blood's like filtered right there. Oh, we got someone watching. What's up? So we're studying renal. Oh, we got two. Cool. So just been going over. Yeah, I'm just gonna keep going. So I'm doing just one of the case study here, and I'm getting to critical thinking questions. Basically, it's just cirrhosis, liver cirrhosis. So yeah, planning to be a dialysis or something. Well, I just got to study. I got a dialysis. I was thinking about being a dialysis nurse. Actually, I've talked to a few dialysis nurses, and it seems like a cool gig. Super mellow. So like what are the positives I got out of being a dialysis nurse? I've talked to a few. DaVita is a huge company. They probably go check out DaVita because you don't have to be in one place. You can be you can travel to different units, different hospitals that people need dialysis, but they don't have like Medicare's paying for it. They don't have someone. They're not going to get paid if they dialyze them. They need to get funding from because DaVita that way they hook it up. So the nurses are great because it's not your patient, right? You're not the primary nurse. You got a primary nurse on the floor. So you come in, you get labs, you make sure they can receive dialysis, get a set of vitals, make sure they're ventilating okay, pressure's all right, got a good fistula or good access. Are you going for ADN? I'm in an ADN program. So I graduated December. So yeah, and then we'll work on the BSN once I feel really comfortable. Once I feel proficient, I guess. Thank you, sir. I'm almost there. So I've been like looking at like so yeah. So I've been looking at so I always like to study look at like how doctors study because they need to know so much more information than I do. So I like to look at what they're studying for like step one, like how they studied for step one, like the good ones that are scoring like 250 plus. And so that's kind of how I'm going to be studying for the NCLEX. Similarly, because they use UWorld for step one, so I'm going to use UWorld for NCLEX, so I'm just going to study like a doctor does. So, all right, so I'm going to keep studying, guys. All right, here we go. So I got critical thinking questions for this guy, 55-year-old Native American guy. He's got cirrhosis of the liver. His main issue to me is his Billy's 15, serum ammonia's 220, so that's high. AST's, ALT's, AST's 190, ALT is 210, so they're a little bit elevated. Um, so basically, we're talking about Mr. B's clinical manifestations of liver failure. For each manifestation, explain the pathophysiological basis. So his total billy is going to be elevated because he's not able to conjugate it and convert it and get it into the bowels. So he's going to have like dark brown pee-pee. Serum ammonia is 220, so that's really bad. I think you're at risk for pleural effusions with your ammonia is that high. You're at risk for pericardial effusions. You're at risk for encephalopathy, so you're at risk for falls, risk for injury, risk for all kinds of crazy stuff. And I've had lots of encephalopathic patients. So I used to work chemical dependency, and we get guys coming in long-term cirrhotics who are trying to get off alcohol for the first time in 20 years because the doctor said, bro, you're going to die. You got. And so I've actually watched one of my patients die in front of me. He came in with abdominal pain. He was a cirrhotic, and he was an alcoholic. He was only like 35. And I knew him. He'd been on my unit like 4 times. He'd been through the whole program. He was a nice guy, dude. Super rich, too. Really nice guy. And I've taken him, I've helped him detox off alcohol so many times, and I've taken him down to AAME so many times, and I freaking saw him die. I was doing my clinical, and I worked while I was doing my clinical. And he came on my unit. They had to transfer him up to us because they had to put him on hospice because he just deteriorated so freaking fast with liver failure. Like, he died in 3 days. Like, liver failure came in with abdominal pain, normal, and by day 3, he's like contracted, freaking yellow as a highlighter, eyes rolled in the back of his head, encephalopathic, agonal breathing, satting at like 50, just dead, just ready to go. And pulling all measures, just comfort measures, giving him PCA. He couldn't even use a PCA, so he's so dead. So they would just be giving meds all around the clock, comfort care. And it was quite shocking to just go in the room and to see his name and then go in the room. Yeah, so it's really, liver failure sucks. I've been definitely seeing it firsthand. So, clinical manifestation of liver failure. So you got these CITES, right? You get the low albumins. You're gonna have third spacing. The third spacing will push on the belly, while expands the peritoneal space. Also, pleural effusions, like they're gonna come hand in hand. So that'll press against your returning blood flow, like your inferior vena cava. That is going to be pinched off by all the pressure. So you can have like vena cava syndrome. You can have, I guess inferior vena cava syndrome. I don't know if that's even a thing. It's more of a compartment syndrome, I guess. So you have compartment syndrome. You can have difficulty breathing. You're not able to expand your lungs completely because your diaphragm is being pressed by all the fluid. So that's kind of one of the physical changes that occurs. Clinical manifestation of failure. Okay. I think I've harped on that enough. Pathophysiological basis. Explain the significance of the results in his laboratory values. But I think I kind of already went over that. But the ammonia is huge, because you really get altered pretty quickly with that. And that encephalopathy can cause, I think, permanent damage. So the cure to fix that is lactulose parties. I've had lots of lactulose parties. So like when these guys come in, they have cirrhosis. And they're encephalopathic, meaning they're altered, their brain's all screwed up from all the ammonia concentrations. The ammonia can be released from the lactulose. It's a diuretic. I think it's osmotic diuretic. Anyways, what it does, it pulls all lactulose into the stomach. Well, the problem is if you got an altered old man who doesn't know what's going on, and now you're going to give him explosive diarrhea, and he's weak. You're weak when you have high ammonia. So you don't have the same strength, you don't have the same coordination. Everything's all goofed up on you. So you have to have a sitter at the bedside, and that's usually this guy because I'm not a nurse now, right? So they put me as the sitter. So I'm the sitter. So I'm gonna have the lactulose party. That nurse is gonna go get him a little bit of lactulose, and she's gonna leave the room, and she's gonna rely on me to be able to get him on the bedside commode when he's ready to explode out of his bottom, you know what I mean? And it's not just one explosion, we're going to keep blowing that thing up until his ammonia's gone. So I've had lots of lactulose parties, and you just play and poop for 12 hours. So it's something I do regularly, very often. I used to, at least. I haven't done a lactulose party in at least a month, maybe. I didn't think I did one last month, so it's that's a rough one. It's kind of fun though. I mean, it sucks, but you just gotta enjoy your life, I guess. I don't know. If Mr. B begins to, okay, on laboratory, okay. If Mr. B begins to manifest signs and symptoms of hepatic encephalopathy, what would you monitor? Oh, okay. What measures should be instituted to control and decrease the ammonia level? Oh, it looks like we just talked about that. Great review. I have to give a renal. I'm sorry, almost reconnected. I lost connection. So, hepatic encephalopathy. I'm going to read the question one more time. If Mr. B begins to manifest signs and symptoms of hepatic encephalopathy, what would you monitor? All right, well, so we'll start with that. So we're going to monitor mental status. Mr. B, do you know where you are right now? Mr. B, how did you get here? What's your name? What day is it? Who's the president, right? If he can't answer these simple questions, if he starts to become combative, if he starts to if he's, coordination, we check coordination, orientation, mentation, right? And baseline. So where do we start and where are we now? Because it progresses very quickly. I can have a patient come on in the morning. Yeah, his ammonia is a little bumped up. Yeah, he looks like crap. He's all yellow. He looks like a highlighter. Scleras are yellow. But hey, he's mentating okay. He's still walking around. Yeah, he's tremulous, but he's not, he's not freaking taking his clothes off and walking around the halls. So, he's okay. We're definitely going to work on the lactulose or at least work on his fluids, whatever. But they can deteriorate pretty quickly. So I've seen these hepatic encephalopathies that come in chilling for the first 6 hours, and then I don't know what happens. Their concentration gets to a certain level, and boom, they don't remember where they are. They don't remember their name. They think they're at home. They're pissed at you because you're in their freaking house, right? Get out of my house, that kind of thing. So unfortunately, okay, so as a nurse, one, safety is key, right? We got to keep this guy safe. We got to keep the staff safe. He's gonna have an IV if he's this sick. We need to keep that IV safe because they're gonna pull them. So having an attendant at the bedside is huge. Having a one-to-one at the bedside is pretty big, just for safety. Another thing is injury. Maybe two beds. Two side rails up. Put the call light down. You might want to use a bed alarm. Turn that bed alarm on because if they start getting up out of bed and no one's paying attention, you want to be able to hear, "Hey, Johnny's out of bed, right? We need to go check on him." So bed alarm can be huge. Also, worst case scenario, we can give medications to maybe calm them down, get an order for mitts or get an order for restraints if we have to. Let's say they're pulling at stuff. If they're pulling at stuff and my one-to-one's having to hold both arms to keep him from hurting himself because he's so confused, yeah, we might get an order for mitts, might get an order for restraints, might get an order for a posy vest if just for safety. So those are kind of things you go down the encephalopathic road. You go down that hepatic encephalopathy, you end up kind of going there. And then, worst case scenario, if you're given this lactulose, now I've never done this, but if we're giving lactulose, not okay. I put in BMS systems because you know what BMS is, bowel management systems, rectal tube. Common nomenclature, rectal tube. It's like a Foley times 100, right? You got a Foley, but the tube isn't a 18 French. It's a freaking massive clear tube with a big balloon on the end with a 50 cc. You smash it makes a big old hole in their butt, and makes it patent. So if they're having usually do it for C. diff. Like if you're having explosive diarrhea, and you're having like copious of like it's like a fountain, because we've been there. I've been there. I've done that. I got the t-shirt. I've played with poop fountains. I've played poop fountains for sure a bunch of times. So that's usually what the BMS is for. So I wouldn't recommend a BMS. But monitoring bowels, how many bowel movements has he had? What does it look like? Because a lot of times it's going to be black and it's going to be loose. It's not good. It's not a good look. Okay, so that's what I would do for hepatic encephalopathy. You get the lactulose. You maybe can give fluids, but it's also difficult because you can't really give fluids to a guy whose albumins aren't there. They're in third spacing already. Even if you're given, even if you're given just isotonic crystalloids, you can end up throwing fluid because it's just going to keep going out. They're not going to be able to hold it in their vascular space. So you can overload them if you start trying to give fluids and stuff. So it makes it hard. You might put them on MPO status. I mean, I don't know about that. So I don't I wouldn't know about MTO. I mean, he's a risk for sure. He's definitely risk for aspiration if he's altered like that. So what would you monitor? Okay, so we'll monitor his mentation. We'll monitor his vitals. Monitor his bowel movements, his fluid status, because you can lose lots of fluid. Electrolytes, you can lose electrolytes. What measures should be instituted to control or decrease the ammonia level? Okay, we already talked about that. Those are, what else can you give? I don't know if there's anything else to give. To me, that's what I know. So we'll go there. If there's others, hey, you probably need to study more. If there's more stuff, maybe there's more. I don't know. I'm more real world. And it works for me. So the test, I can basically reason through whatever test they throw at me. So I'll just, whatever they say, I'll just try and figure it out. If there's something I don't know anything about, shoot, man, I usually don't get there. I'm usually not there. Mr. B was being closely observed for the possibility of gastrointestinal bleeding. Why is this considered a possible complication? Okay, possible complication of gastrointestinal bleeding, GI bleeding. Okay, so when we talk about GI bleeding, we're talking about upper GI or lower GI. So with upper GI, you have varicose veins in your esophagus. You have varicosities, esophageal varices, and so that can cause bleeding, right? You can have really poor cofactor production in that liver if it's really shot. So you're at risk for bleeding because you don't have any cofactors if you have micro tears in your GI tract if you're lower, and you have poor pressure control because you don't have your third spacing, your fluids not intravascular fluids not being managed appropriately. So you're at risk already. Just if you have pleural effusions, you have a risk for pleural effusion. You have a risk for bleeding. I think especially with platelets low. But I would think varices are kind of the direction we're going with this. Why is this considered a possible complication? Gosh, yeah. So I think I discussed that. It's because of the hepatic portal vein. So that hepatic portal vein is pretty jacked up, right? So if they're going to have varices, if they have varicosities in their legs and they have varicosities in their butt, like hemorrhoids, then you can probably guess that they're probably, if you scope them, you're going to see something in their esophagus. You're going to see bulging varices in their possibly bulging varices in their esophagus. So you have just like kind of backup of blood from the hepatic portal system into the GI tract, and that GI tract connects and perfuses and innervates the entire thing. So your esophagus as well as your stomach and your small and large bowel. So I would say, yeah, GI bleeding. I'm thinking varices. In the early stages of cirrhosis, what can be done to control the disease? Well, stop drinking. Right, you can stop drinking. That's a good way to control the disease. You can get treatment for Hep B. You can get interferon. You can get or C, Hep C. You can get interferon. Yeah, I mean, what? Stop the process by limiting what's causing the problem. I guess. That's kind of a stupid question. Based on the assessment data presented, write one or more nursing diagnoses. Are there any collaborative problems? All right, I think I just went over a bunch of nursing diagnoses. I don't really want to repeat them. All the risk, anything I say risk for, that's a nursing diagnosis, right? So instead of saying like pneumonia, I'm saying risk for injury, or risk for bleeding, or risk for aspiration, I said risk for injury, risk for fall because of his inability to, mentate, the inability to function properly, as CNS functioning. All right, that's it, man. That's their chapter 42 case study. That's the case study on cirrhosis. I mean, it's okay. It gets you thinking. It gets me thinking, I guess. I'm not going to go over the lectures. I feel pretty good with injuries. I mean, kidneys. We're on kidney and GI. This test is going to be kidney GI. So renal failure case study. All right, I'll do a renal failure case study too. So I feel pretty good with renal. I feel pretty good with GI. What's this? Renal and GI. Oh gosh. Okay. All right. Dude, cirrhosis, we're going to go over more on the cirrhosis for GI. There's so much for GI. That's not a problem, though. I think we can go through that. I'll definitely go to class. There's a little tip, guys. Hey, if you're in school, go to class. I'm watching, I'm on YouTube, and I'm, looking at all these different people vlogging and stuff, because I just, it gets me, I just love seeing, because it's all millennials, I love seeing this new generation of medical professionals in their infancy. All these medical student bloggers making videos. And they're so great. It's amazing. But some of them aren't so great. So you start looking like, whoa, dude. We'll see how that one goes. Like if you're not going to class, maybe there's people that are just on the next level. They don't have to go to class. You say, oh, this is 2018. I don't have to go to class. Yeah, okay, that's fine. You don't have to go to class. Maybe you study incredibly or self-didactic. I'm self-didactic. I can teach myself all kinds of stuff. But it never hurts to sit in a room with a freaking doctor and listen to him talk on something, on a subject that he cares about for a few hours, especially if you don't want to be one. So, that doesn't really matter. It's here nor there. Okay, so let's do this acute renal failure case study. Mr. C presented in the emergency room with a complaint of severe crushing substernal chest pain. Okay. A 12 lead EKG showed an inferior MI. What? His vitals were heart rate 110, BP 94.46, respiratory rate 20, and temp 37.0. Why did it say 37.0 Fahrenheit? That'd be 37.0 Celsius. That doesn't make sense. 37.0 Fahrenheit is freezing, sweetie. That's not correct. Okay, so that's a mistake. Mr. C was not a candidate for thrombolytic therapy as a coronary angioplasty with stent. Okay, hold on. Not a candidate for thrombolytic therapy. Yeah, no one is a freaking candidate for thrombolytic therapy for inferior MIs. Like, that doesn't even make sense. We don't do that. That's not something that's actually done anymore. So a coronary angioplasty, PTCA, okay, percutaneous transluminal corneal angioplasty with stent was successfully performed. Okay, cool. Mr. C's medical history includes hypertension controlled by atenolol and osteoarthritis, from which he takes piroxicam. You are taking care of Mr. C 3 days post-MI, and you note the following labs. Sodium's 142, okay. Potassium 4.9, okay. Chloride 100, okay. CO2 26, okay. Glucose is 158, alrighty. Creatinine 2.2. Oh, here's our kidney injury. And BUN is 28. She has fine basilar crackles, okay, and +2 pedal edema. That doesn't sound good. His previous 24-hour INO is in. He had 15, 10, and out he had 390. Okay, hopefully that's accurate. Mr. C is diagnosed with acute renal failure. All right, so that's our case study. What is abnormal about Mr. C's assessment? Well, his glucose is high, his creatinine is high, his BUN is a little high, he's got the basilar crackles and +2 pedal edema, and his output is not positive, is not equivalent to his input. That's my abnormal, and he's got the whole stent thing. He's got a heart, he had heart attack. Describe pathophysiology of acute renal failure: pre-renal, intrarenal, post-renal. Okay, so pre-renal, he related to like a renal artery stenosis. He related to vascular hypovolemia. So if you don't have enough volume to perfuse the kidneys, they can become injured. If you have renal stenosis where there's not enough blood flow to the kidneys, or there's a restriction in blood flow to the kidneys, it can cause renal failure. Hey, what's up? You made breakfast? Oh, my wife made breakfast. Oh, wow, what'd you make? Okay. Once Mackenzie gets home, let's do it. Give me I'm just going to answer these there's like 4 more questions. I'm just going to answer these questions myself, and I'll feel pretty safe. I'll feel like I studied. Describe the physiology of acute renal failure. Pre-renal, yeah, that's going to be a vascular issue. Intrarenal, that is related to tubular necrosis. Pre-renal volume depletion, yeah. Vasodilation, yeah. Decreased cardiac output. There you go. Cool. Perfect. Yep. So pre-renal, that's going to be, yeah, like an ischemia. It's like a heart attack for the kidneys. Pre-renal is heart attack for the kidneys. Intrarenal would be like acute tubular necrosis. Maybe cystic. You can have cystic issues that cause let me see, like polycystic kidney disease. Is that going to cause acute renal failure? Polycystic kidney disease. Acute kidney injury. Let's see. Acute kidney injury induced hallmarks of polycystic kidney disease. Yeah, so that can cause it, but I don't think we're going to wear it. Well, let's see. So we got another comment. I missed that. Hematological problems. Okay. Intrarenal hematological. Okay. I know. Acute tubular necrosis will cause will be intrarenal. That's the one I know, and I think that's what we went over. So I think that's the only one I'm going to worry about, I guess. Let me see. Intrarenal causes of intrarenal. Okay, so intrarenal AKI. Intrarenal acute kidney disease. Let's see. Management. This is from American Family Physicians, acute kidney injury, a guidance for diagnosis and management. Key recommendations for practice, definitions. Okay, hold on. Let's see. Increase etiology. Here we go. Uh, Intrinsic renal, glomerular. So post-infectious or glomerulonephritis. Oh yeah. So glomerulonephritis, pyelonephritis, tubular necrosis. Those are the big ones. That's intrarenal. Interstitial, you have penicillin analogs like cephalosporin, sulfonamides, ciprofloxacin, acyclovir. Okay, let's see. Interstitial, okay. Rifampin, dilantin, interferon, proton pump inhibitors, non-steroidal anti-inflammatory drugs. So that can cause intrarenal tubular necrosis or damage to the into the capsule or the capsule of the kidney or the not the medulla. The what's the capsule of kidney? What's it called? It doesn't matter. We'll move on. What is the most likely cause of Mr. C's acute renal failure? Okay, wait, we didn't talk about post-renal. So post-renal failure or post-renal acute kidney failure or would be like ureter dilation or like a stone that got stuck or like a dissection could cause it, I think. No, I don't know, a dissection. Dissection? No. No, I don't think that's correct. Obstruction. Post-renal obstruction usually is what does it. And then you have urine backing up, and then that can cause damage. What is the most likely cause of Mr. C's acute renal failure? Well, he just had a freaking heart attack, and he's 3 days after that heart attack. His blood pressure was a little low, 94/46. We don't know how low it ended up getting. He got PCI. So pre-renal, decreased blood supply. Yeah. Renal failure of nephrons. Post-renal obstruction of outflow. Yeah. Yep. And I'm thinking, this is probably pre-renal. He had a heart attack. He's got +2 pedal edema and basilar crackles, so he might have some heart failure going on, and he might just be have been hypotensive for way too long. It's inferior MI, so with inferior MIs you can have hypotension. I've dumped inferior MIs. So that's a little tidbit. Like, let's say you have someone come with an inferior MI. So inferior MI is like ST elevation greater than 0.2 or 0.02 in 2-3 AVF, I think. 2 and 3 for sure. Yeah, 2-3 AVF. I think that's inferior. If you give sublingual nitro to that, I've watched those right-sided MIs dump their preload. Like they come in 120/60 with an inferior MI, we give them sublingual nitro, and it's like 40/20. And we're like flooding them now with fluid. So that can happen. So I would say maybe it could be. I mean, most likely it's going to be a pre-renal hypotension of some sort, maybe cardiogenic hypotension. What is the most likely cause? That's my guess. The next day, Mr. C's assessment reveals previous 24-hour INO is 1205. Okay. And in is 1205, out is 340. His sodium is 132. Whoa. So he moved from 142 to 132 in 24 hours. That's not good. His potassium is 5.2. All right, so we have that. Okay, so this, let's see. Creatinine is 2.3 BU130. Mr. C's physician orders that he be placed on a continuous telemetry monitoring. Okay, yeah. Start on Lasix IV. Okay, and have a renal dietary restriction. All right. Describe the rationale above. Well, clearly his renal failure is not resolving. He is oliguric because his output is so poor. He's taken in way too much fluid for how much output's going out. His sodium is not being managed. Sodium is not being managed or is not being regulated appropriately by the kidneys. And his potassium is not being regulated by the kidneys. So his potassium keeps bumping. So what's nice is we're going to give Lasix. So hopefully that Lasix will start maybe getting rid of a little bit of that potassium, although it's also going to get rid of the sodium. So he may need sodium replacement. He may need potassium replacement too if it starts to drop too low. creatinine 2.3, BUN 30. So yeah, he's definitely acute kidney injury. Describe the rationale above. So the rationale for the Lasix and the Tele, if your potassium is 5.2, you can have ectopy, you can have peak T waves, you can have issues like cardiac issues. So let's just see. We'll get a nice little long list because there's freaking okay. So hyperkalemia, cardiac symptoms. So I know there's a big old long list of them. So let's see: muscle weakness, flaccid paralysis, depressed or absent deep tendon reflexes with hyperkalemia. I think you can go into VTAC, right? Let's see. Peak T waves. I know you get peak T waves. I think you get a shorter QT. Let's see. Okay, let's see. Let me keep going. Hyperkalemia symptoms, signs of treated insulin, hyperkalemia revisited, hyperkalemia cardiac, effects on the heart. But potassium is critical normal function. So you have okay, that's not important. Normal heart, okay. Most typical effect of having related to electrical rhythm of the heart. Yeah, so here we go. This is what I'm talking about. So you get the peak T waves, and you get a widened QRS complex. Peak T waves, small or indiscriminable P waves. V1 will be a wacky R wave progression precardially. So V1 will be like isoelectric QRS, and then you'll move into a weird R wave progression with peak T waves and small or indiscriminable P waves. All right, that's fine. And I think it starts to elongate. Okay, so what typical renal dietitian restrictions? What are the typical renal dietary restrictions and why? Renal dietary restrictions. So if someone's on a renal diet, they can't have phosphorus because that screws with their calcium phosphorus balance. They can't have high protein because their body will metabolize it, cause increased ammonias. I think, is that right? No, increased urea nitrogens. They can't have a ton of fluid. You got to be fluid restricted because they're not getting rid of anything. What else? High carb. I think it's high carb. So, and why? Well, they can't get the fluid because they can't get rid of it. I think the potassium restriction because it can get too high. So they can't eat like a ton of potassium. They can't have soda because if their phosphorus is too high, they'll screw with their calcium. I said that. Okay, Mr. C responds well in the above interventions and is taken off of Lasix IV. Okay, cool. After 2 weeks, Mr. C's urine output increased to 250 over 24 hours. Okay, so it's a little over 100 an hour. His K is 4.4. Okay, his creat is still 2.1 with a BN of 26. What phase of acute renal failure is Mr. C in now? What potential problems occur to this phase? So this is where they want you to be able to differentiate between the oliguric phase and the polyuric phase that precedes the oliguric phase after you've reperfused the kidneys. So once you've corrected the problem, you've reperfused the kidneys are functioning normal again. They go into overdrive, right? They start pushing the fluid out quick. Starts, so you're going to see an uptake in their glomerular filtration. You'll see an uptick in their urine output. And we're not seeing his potassium or his creatinine come down. So that means he's still injured. Describe the patient teaching for Mr. C prior to discharge. Okay, well, he's got the MI. So that's, to me, okay, yeah, he does need to worry about his acute kidney injury. Absolutely. But he's got some bigger fish to fry with this whole MI thing, right? So, talking about, and it's all, yeah, there's a lot to talk about. Describe patient teaching emergency prior to discharge. So we're talking about lifestyle change. It's going to be number one, lifestyle change. Signs and symptoms of poor renal function. So, like, are you retaining water and heart failure? So renal function and heart failure kind of go together. So are you retaining water? Are you having difficulty breathing? Are you having chest pain? You stop peeing? Are you having retention, meaning like if you're having abdominal pain, if you feel like your belly's getting full, if come back to the hospital. Make sure you maintain strict regimen with your medications. Talking about his diet, cardiac. He's going to need a cardiac and renal diet. That's a bland, boring, horrible diet. And honestly, I mean, I don't know how you stick to that diet. Personally, I couldn't stick to it. I'd rather starve myself than stick to a renal cardiac diet. I'd rather starve, and I do starve. I'll do extended water fasting and stuff like that. So, and that actually keeps you healthy. So I'm not going to tell my patients to do that because there's not enough literature yet to be able to back what I'm saying. I'm not going to get, but there's some incredible science that's coming out right now by like Dr. Fung in Canada, Fung, Jason Fung. Dr. Jason Fung just came out with a pilot study regarding extended fasting and reversal of type 2 diabetes. He cured these guys who had 25 years plus type 2 diabetes, cured them in 18 days. They were off all their medication with normal blood glucose, and their hemoglobin A1C was back to normal. Within 18 days of his fasting protocol, had him freaking fixed. 3 guys. He did it to 3 guys. He's going to increase it. All right, so describe patient teaching. I did that. All right, cool. That's it for that case study. Not bad. Not bad. I think that's all my studying. That's it. I'm going to call it, guys. I'm going to call it. And maybe we'll do another one of these at some point. So thanks for hanging with me. This is fun. And I'll see you around, okay? I'll give an update. So I don't take a test next week, so more GI stuff, but I'll keep updated on my preceptorship. I got a 12-hour clinical in the ER, Level 2 Trauma Center that I work at Tuesday. So maybe I'll do another video after I do that. And we'll just keep studying here. We got almost done. Home stretch, guys. And I'll probably do UWorld. When I start doing UWorld, I'll start maybe study with me, do UWorld. So if I'm allowed to. I don't know if I have to sign something that doesn't let me to, but we'll figure it out. All right. See you later.